Hello, everybody. Welcome to our webinar. We're excited to be here today presenting to you on making LSVT treatments work in your clinical world. My name is Beth Peterson. I'm a speech language pathologist and one of the LSVT Loud faculty instructors, and I'll be moderating the session today. And I have four great expert panelists from various clinical settings that will be talking to you about implementing LSVT Big and LSVT Loud across various settings. I'll just briefly introduce them all here, and then as they take turns presenting today, they'll tell you a little bit more about their background. So first we have Jenny Tecido. She's a physical therapist, and she'll be talking about outpatient therapy and telehealth and LSVT Big. And then we have Heather Hodges, and she's on the LSVT Loud side, and she'll be talking about outpatient and telehealth on the LSVT Loud side. Then we have Bernie Kozer, who's an occupational therapist who will be talking to us about home health and skilled nursing facilities. And then last but not least, we have Dr. Michael Hyland, and he's a physical therapist who will be talking to us about LSVT Big and the mobile practice setting. So you may see that we are a little LSVT Big heavy. A lot of the topics that you'll hear about today can be applied to LSVT Loud or LSVT Big, but if you do have any questions about that, feel free to type that in the chat or ask us after, and we can let you know how LSVT Loud might apply to something that one of the LSVT Big panelists was discussing today. And you do have in your slideshow, which is also in your handout, a detailed biography of each of the presenters, so you have that for your reference. And in terms of disclosures, we have Jenny, Heather, and Bernie have both financial and non-financial relationships with LSVT Global. Non-financial relationships include a preference for LSVT Loud and LSVT Big as treatment techniques, and their financial relationships include that Jenny's an employee of LSVT Global, and Heather and Bernie are consultants for LSVT Global, and they receive lecture honorarium. Dr. Hyland has no non-financial relationships to disclose, but his financial relationship includes that he was offered lecture honorarium for the presentation today. I'll just quickly go over some webinar logistics so that you know what to expect. Right now, everyone in the audience, your microphone was muted when you came into the webinar. That's just to make sure that we don't have background noise from the various environments where you're joining us. So if you do happen to unmute or get unmuted during the presentation, if you don't mind muting it again, just to make sure that we don't have that feedback, that would be appreciated. So thank you. And if you have any questions during the webinar, you can type them in the chat box on your webinar control panel. And then depending on kind of how the flow is going, we can either address that as, a panelist is speaking, or at the end of the webinar, we'll kind of just see how that flow goes. And as for the handout, you should have been emailed a handout of these slides, I think about an hour before the webinar it went out. Once I finish this intro, I can also drop that into the chat so that you have that here. And then I'll also put it in a follow-up email that you'll get either later today or early tomorrow so that you have that handout for your reference. We will have a survey at the end of the webinar that we appreciate if you can take. It helps us, tailor our webinars to make sure that they are topics that our participants want to hear about. And then any feedback, positive or negative, that will help us, make these webinars the best that they can be. It should only take about 5 minutes or less. And so it will display right on your screen after the webinar, or it will be sent in a webinar, the follow-up webinar email. You'll have a link to take it if you're not able to take it right after the webinar today. Then I'll talk for just a moment on continuing education units. So this webinar is not ASHA or state reported for continuing education units, but if you're a speech, physical, or occupational therapy professional and you'd like a certificate so that you can self-report the CE activity, you can, if you're viewing live, you can just email us after you complete the webinar today. Let us know that you watched it, and then we'll send you a certificate. It can take up to 2 weeks from the date you request, but it's usually done sooner than that. If you're watching on demand, you'll have to take a survey so that we know that you've completed it. And the survey link can be found underneath the webinar description, either on the webinar section of our LSVT Global website, or if you're watching in YouTube, it's under the webinar description in YouTube. And attendance for the full hour is required to earn a certificate. As for learning objectives today, so the goal is that at the end of the webinar, you'll be able to identify potential challenges and solutions that will help you support delivery of LSVT Loud or LSVT Big in various clinical settings. be able to summarize strategies for delivering these treatments to clients of varying disease severity levels and cognitive abilities, outline ideas for creating salient activities for clients in any clinical setting, and determine whether these protocols can be successfully delivered via telehealth. And then lastly, explaining strategies to obtain reimbursement in these various clinical settings. So the overall goal is really that you walk away from this webinar understanding that LSVT Loud and LSVT Big can be applied in a lot of different settings, and hopefully some of those barriers you might have in your mind, you'll hear from some of these panelists how they've overcome those barriers and been able to successfully implement these protocols in those settings. So before I pass it off to our panelists here, I'm just going to report on the top 5 barriers that we heard from clinicians. So this was an informal survey that was done in preparation for another webinar, asking clinicians who deliver the treatment, what were their top 5 reported barriers? What was making it difficult to deliver treatment? So kind of some of the themes that you'll hear throughout our speakers today have to do with transportation, financial concerns, so insurance and reimbursement, scheduling and staffing, so making sure they have, the ability to schedule the intensive dosage that's required for the treatments, tolerance, compliance, and carryover for their patients. So how do we make sure that patients are motivated and compliant to do the treatments? And then lack of knowledge. So making sure that, referring providers, therapy supervisors are educated in the treatment protocols so they understand, the rationale for the intensive dosage, why it needs to be done the way it is, to help them take in those referrals and get them on their schedule. So those are some themes you'll hear throughout the presentations today. So I'd like to take a moment and introduce our first panelist. And so first we have Jenny Tecido, and she's going to represent LSVT Big in the outpatient setting as well as telehealth. So Jenny, if you don't mind just taking a moment to introduce yourself to the audience.
Hi, everyone. My name is Jenny Tecido, as Beth introduced, and I am a physical therapist. I spent 21 years in neurological outpatient clinical care with expertise in Parkinson's disease. So I taught a wide variety of diagnoses, from stroke to spinal cord injury to brain injury, but my favorite people are those with Parkinson's and movement disorders, and it became my specialty. I transitioned about a year and a half ago out of clinical care, and I now work full-time for LSVT Global as the Director of Innovation and Communications, as well as I serve as the LSVT Big clinical expert. So I help support all of our certified clinicians with their questions, their concerns, via email, conversations, and helping out with a lot of different educational opportunities as well. I have been a PT for a long time, and I'm super happy to be here to talk with you guys.
Great. Well, thanks, Jenny. We're happy to have you. So I think we'll jump in, and a question that we get often is scheduling. So did you have any issues scheduling those 60-minute sessions in outpatient care? We get some questions from clinicians saying, their facility is transitioning down to 45-minute appointments or 30-minute appointments. So how did you work with management to accommodate that required 60-minute dosage?
Yeah, so for those of you that may not know about LSVT treatments, the treatment protocol is delivered in a 4 times a week for 4-week treatment structure, and those appointment visits are to be 60 minutes in length. So I had I think, a wonderful opportunity to slide this treatment into my facility really easily when I got certified back in 2009, because we automatically had 60-minute appointments for neurological diagnoses. So I was pretty lucky. I was able to take the course and go right back to our clinic and implement it within our schedule, and it was easy to do so. However, our company went through a merger with a different company some number of years ago. And in that alignment with that new company, they really wanted to align their orthopedic outpatient therapy services with their neurological outpatient therapy services, and made the overall across the board decision that all treatment sessions were going to go to 45 minutes only, which was difficult for those of you that might be therapists and work with patients. Squeezing everything into a 45-minute session is hard sometimes, when even it takes time to simply get to the treatment space. So we were all not happy about this, but it did move forward, and it was the way things went. Now, what we did with LSVT, and this was true for both LSVT Loud and LSVT Big, is we went to management to educate them on what LSVT treatments are, what the requirements are, and that we can't just reduce the dosage by 25%, which if you drop your treatment sessions from 60 minutes to 45 minutes, you're really reducing the dosage by 25%. So we're taking a clinically researched and evidence-based program that knows that this amount of dosage is expected to produce these kind of results. We can't assume that a decreased dosage would do the same. So we really went to management and said, we need these appointments to maintain at 60 minutes. We agreed that we would allow them to flex our schedules a little bit to accommodate that, where if we needed to slide our lunch time back a little bit or forward a bit or move around our paperwork time a little bit, that we would be flexible doing that. And if they would just be flexible with allowing us to schedule these patients in 60-minute appointment slots. In the end, it took going from talking as a community of therapists to going to our level 1 managers, our level 2 managers, and beyond, all the way to the top to try to win this battle. And when you're talking with management, and we talked with management, we really talked in dollars and cents. So in a 60-minute session with PT or OT, we can bill for 4 units of treatment. So it's not like we're losing units of treatment. These patients attend very regularly. They very rarely cancel. They have really great attendance rates, which cancellations really hit the bottom line in an outpatient clinic. These patients are also going to trust us to return for other things. So if they do have a knee replaced, they have orthopedic concerns, they need OT for something else, they need to see one of our psychologists in our building, they are going to trust us to come back to us. So these are repeat customers, if we want to talk in dollars and cents and things that management understands. And in the bottom, at the end, what we said was, if you can't accommodate us seeing these patients for 60 minutes, we're going to have to send all of these patients to our competitors in the area. And that was not received well. So, knowing that we could potentially lose business to our competitors, I think was one of the things that helped convince them. And we were able to maintain and continue with those 60-minute appointments specifically for this population of people.
Great. Those are some great tips. I think that justification, that dollars and cents really spoke to who you needed. And it's nice to hear that you were able to get it going again. Mm-hmm. So thanks for sharing that. So you also have some experience with telehealth. So I wanted to ask if you can kind of discuss some of the advantages or disadvantages with telehealth, doing some sessions over telehealth and some in person, or doing them all via telehealth.
Yeah. So, we had this opportunity that came out of this horrible pandemic that we went through, where insurance providers began to allow us to bill for therapy via telehealth. And we fight to this day to maintain that ability and try to keep that. Our national organizations are trying hard to maintain that. And so we were able to, in those times, start to see people with either a combination of in-person and telehealth sessions, or we even were treating some fully telehealth during that period of time. What telehealth really provides you the opportunity to do is when patients have issues with the 4 times a week frequency of being able to get to you, being able to attend therapy, a really great solution is to say, hey, what if we saw you here in the clinic 2 or 3 days a week and we did that other 1 or 2 sessions via telehealth from their home? It's also a great opportunity to actually have some eyes into someone's home environment, where they live, their space, their actual concerns about how they move, rather than trying to mimic that environment in an outpatient clinic environment. And so it was really a great opportunity. Now, and Heather will also talk on telehealth, so I won't take too much time on this topic, but some special concerns that come along with doing LSVT big via telehealth is, can I keep my patients safe? So, when you have a patient that's doing exercises that maybe challenges their balance and we're concerned about falls, is that person a good candidate for this? So looking as a clinician at screening our patients to determine who might be appropriate for telehealth, because telehealth might not be for everyone. People need to understand how to use technology well, how to position a computer, tablet as something to be able to see you and for you to see them, as well as we want to make sure people are safe. So if we did feel like someone was a good candidate, but we questioned a little bit with safety, one of our requirements was that if we're going to do our telehealth sessions, that we want someone else home in your home with you while we're doing our therapy. So if there is a concern, there's a balance issue, there's suddenly a physical issue that we can't reach out through the screen and help, that someone's actually there, that we have emergency contact information so that we can right away reach out if we need to connect with someone to get help. And the other thing is just maybe adapting the way we do exercises. So in LSVT Big, we as clinicians can decide what position we're going to do the exercises in. Positions that might be quite challenging, we would probably want you in the clinic in person to be able to do those because we want to be there. So if we're doing a telehealth session, we might actually have someone hold on to something while they're doing them, or even sit down for exercises if we're concerned for safety. So it's really a great opportunity for the right client, but not necessarily always right for everyone. And I included some resources at the bottom if you are a clinician wondering about some of those telehealth practice options through our national organizations of the American Physical Therapy Association and the American Occupational Therapy Association.
Great, thanks, Jenny. Those are some good tips there. And with for both outpatient and telehealth, have you had any difficulty with reimbursement for your sessions?
We have not had any trouble with reimbursement. And in fact, I have been providing LSVT Big in our outpatient clinic since 2009, back when Medicare did have a cap on therapy services and did have some restrictions on all of that. And I would say in all of those years of providing LSVT Big, I never ended up having someone denied services. We realize as a clinician that when we're writing up our notes and our plan of care, that if we document well the medical necessity for those visits, as well as the reasonable expectation for improvements, that we can be very successful in achieving reimbursement. Now, there may be certain situations where your insurance may require a prior authorization prior to being able to go in for those therapy sessions. I actually saw something just today. There were legislation in the state of Maine passed where insurance companies are not allowed to do that unless it's 12 visits or more. So hopefully we're making some headway where patients are at least given a certain chunk of visits before prior authorization is required. But a lot of insurances might do that. So as a clinician, or if you're a clinician, looking at getting all 16 of those treatment sessions authorized before you start treatment so that you know that you're not going to have a disruption in your plan of care, and then help out with resources. So if someone has financial concerns over the amount of their co-payments, their co-insurance, are there different discount plans available? Are there payment plans available to help make that more achievable? So if someone does have a high copay, but we can arrange a payment plan where you're not having to pay all those copays in 1 week, but you could spread those out over a number of weeks beyond the treatment, maybe that would be a feasible way to help with that as well. And then I would encourage clinicians and people living with PD and other diagnoses pursuing this treatment to look for your local organizations. So the foundations and organizations in your community that may actually have funds available to help support that. We stumbled upon in the state of Minnesota where I lived that through one of our, where I live currently, I guess, where one of our organizations would allow up to $500 a year. You could apply for a grant fund to help cover the cost of exercise-based treatment options and things for Parkinson's. So there's an application to fill out, and the money did run out at certain points in the year when their fundraising was low, but you can apply for that and help out with that. So know that there's options out there when you start to dig and look.
And I know you had this slide too. I don't know if there's anything you want to touch on with this.
Yeah, just more so that there's a couple of resources here. I think if you are a clinician out there, there's a lot of myths that there still is a cap on therapy services in the outpatient world, and that is not true. It went away, I believe, in 2018. So it's been quite a while since that cap went away, but it more might be management rules or restrictions on saying that we don't want to go past what they call now a threshold because they're concerned about a potential audit or things like that. So educate yourself on what the truth is. Go to like Medicare's website, to the CMS website, go to your national organization and read about it and learn about it. And then, you know, go to your management and say, this patient needs this evidence-based treatment. we have a reasonable expectation they're going to improve. It is medically necessary. I'd be willing to argue with an insurance company that they need this if need be, and show that it's necessary and that it's going to be okay. We're going to be able to get reimbursement. We'll fight to get it if we have any issues, to help make sure that people living with PD get the evidence-based quality care that they deserve.
Great. Yeah. Thank you, Jenny. So before we move on to our next panelist, if you don't mind just sharing why you enjoy implementing LSVT Big in outpatient and telehealth settings.
Well, when I graduated from school back in, oh gosh, it was a long time ago now. Do I want to share that? 2001. When I graduated back then, how we approached Parkinson's was entirely different. It wasn't until people started falling, it was assigning assistive devices, external cueing things like laser light, things like that. The world of Parkinson's has come so far, and this LSVT Big treatment was the thing that really opened my eyes to the potential of amplitude-based treatment. I love this treatment because in a matter of 4 weeks, I know it's a lot, it's 16 sessions in 1 month, but in a matter of 4 weeks, you see definitive change. You see improvements, you see decreased fall risk, and we have fun while we're doing it. We laugh a lot. I'm from an Irish Catholic family that laughs at funerals. So I like humor. I like to make it fun. We trade back and forth a lot of humor and fun, and we see change. And I think that's why I love implementing this so much in my clinical practice.
Great. All right. Well, thanks for sharing all that, Jenny. We appreciate it. All right, and now we're going to shift over to LSVT Loud side. And so we have Heather Hodges, who's going to talk about LSVT Loud and outpatient clinics and telehealth. So Heather, if you don't mind just taking a moment to introduce yourself.
Yes, it'll be my pleasure, and thanks for being here, everyone, today. So I am a speech language pathologist, and I am based in Denver, Colorado. I have 13 years experience working in an outpatient hospital, and I have also worked with LSVT Global for almost 20 years now. And so I started as a graduate student, and now I have a diverse number of roles in continuing education, patient care, research. So I have expertise, and I'm one of the faculty training members as well. And clinically, my passion areas certainly are Parkinson's, LSVT Loud, as well as swallowing disorders, other voice disorders, and the upper airway and treatment of conditions that affect the upper airway. So working with adults and pediatrics, but I would absolutely say that LSVT Loud is probably my favorite treatment to provide.
Great. All right. Thanks, Heather. So I was going to touch on scheduling with you also. Jenny talked a lot about getting it from the management side and how clinicians can work on their schedule. But how do you motivate patients from that side to come into therapy for that 4 times a week for 4 weeks? Oops.
That's a really great question, because a lot of patients might get intimidated by that, or might feel like there's no way they can fit that in, or might not have the energy to do 4 days a week for 4 weeks. And so when I see them for the evaluation, I come right in and work on motivation. My evaluation, of course, is taking clinical measurements, but it's also there to help educate the patient and their family members. So educating them on the treatment, as well as the home practice, the carryover, so they really know what they're getting into. And I also share with them the research in, sort of a layman's terms type of presentation, so that it's easy to follow and easy for them to see that there is efficacious data, that there is an expectation that as they have a degenerative disease, they actually can improve through exercise. And that those results will last for up to 2 years, perhaps longer for people. And so that is really something empowering, I think, because many don't feel like they have any option for improvement. I'll talk about my clinical experience, the things patients have told me, the success stories that I have, and honestly showing them the video of Shirley, which is a pre-post patient video from one of our research subjects years ago, and they're blown away and they're like hooked in with that. So I also will echo what Jenny was saying about the enjoyment. It's a really fun, energizing treatment. And so I let them know we're going to be working on things meaningful to you. We're going to be tackling talking tasks that are about topics you enjoy. And that empowerment feeling of we're going to make this change. You can do it. And so it is a lot of fun. I think it's one of the most fun treatments that I'm able to provide to patients. And so I really get at it from that point of view. And I let them know if, addressing their concerns about the dedication that it takes. So we work on scheduling, making sure the timing is correct for what's happening in their now and here lives. If there's a special event coming up or a vacation coming up or a situation where they're about to go into a lot of medical appointments, for their diagnoses or other health issues, I make sure that we time the schedule appropriately so that they can be successful at getting that intensity with the 4 days a week for 4 weeks. And so during the evaluation, I'll also have voice playback so that I can play back their voice when I'm not cueing them for loud, as well as while I am cueing them for loud. And that also, I think, really helps sell them of, wow, because of the paradoxical akinesia that exists with Parkinson's, they can have that night and day difference even within an evaluation session. And so showing them that we can unlock it, I think is really motivating for them too.
Nice, great. Some nice tips there, Heather. So now once you have your patient scheduled, what do you do in case of cancellation? So whether it's, transportation, weather, illness, what do you do if there's a break in care?
And that certainly happens. It's a real life concern, I think. So with cancellations, my first approach is to try to be proactive and prevent the cancellations. So if transportation, getting to the clinic is an issue and getting to the clinic safely is an issue, we'll talk about, are there caregivers or family members who can help with transportation? The services, there's a number of non-for-profit services that might be in your area that provide rides to medical appointments, and pointing out that speech therapy or any rehabilitation, appointment is a medical appointment. And so those are often covered by foundations or organizations that provide transportation, as Jenny mentioned too, with the support groups, with other local, like we have Parkinson's Association of the Rockies. Not only might they provide funds to help pay for treatment, but they might also provide funds for transportation. We also look at the timing. Living in Denver, I tried for many of my patients, particularly those with mobility issues, to not schedule them during blizzard season. I tried to avoid those weeks. And so timing of the appointments can really matter for setting up that success. And then also in terms of cancellation, what if your patient has to cancel because they're ill, or you yourself as the clinician are ill? Well, first I would say that when a cancellation happens, there's a proactive way and then there's a reactive way to use your colleagues. Having other clinicians that are certified in LSVT, whether it's for big or for loud, I think having at least one other or more people in your department who are certified, so that if I'm sick, I can rely on my partner, my colleague, to see a patient on a day I might be out ill. Or if a patient has to reschedule, it's easier to reschedule if there's a pool of us to choose from, rather than just one person that they're trying to get in on the schedule. So illness also, we can think of it in the reactive terms of what do you do if a patient misses several sessions? What if they really got sick with something? They had to miss several sessions right in a row. The answer to that is going to be assessing them when they return. You'll find kind of where they're at when they're back from that illness, from that cancellation block, and see if it's a matter of tacking on those missed appointments to the end, or using that extra day of the week that they weren't in treatment to help make up for it. Or for some patients who just had a big backslide or had to cancel early on in their treatment dose, they might have to repeat a whole week or repeat the whole course of treatment.
Nice, thanks, Heather. And can you touch a little bit for telehealth specifically? What benefits have you seen from being able to provide telehealth in the patient's real environment?
Yeah, it's so salient. I think that's really a huge component to this is that there's a salience factor. And so when you're in their environment, they are able to use these techniques in their home. They're able to perhaps talk to family members during the hierarchy or an off the cuff response, be able to talk to them in a different room, or maybe I'm in the kitchen while they're in the dining room. And so I'm able to really put it into real life that you can't always quite replicate in the clinic. I also see for a lot of patients, energy. Takes a lot of energy with those ADLs that are required to get out the door. And so to come to a clinic appointment versus if I'm coming to their house, they don't have to worry about getting in the car, driving, walking from the parking lot up to the clinic, etc. So there's decreased time for travel, that decreased load of pre-appointment ADLs. And then another benefit that I love is the carryover. I'm able to dual task for those patients who are ready for it. I'm able to dual task on particular cognitive or motor tasks to challenge my patients in a very meaningful way. So whether it's playing a game that they have at their house, or they balance their checkbook as we're doing our Oz, something like that. It's very real life. And the same is true with assignment of homework and carryover too. I can really let them know, all right, you're going to be starting your day in the bathroom. Let's put up some signs, or let's practice doing your Oz in the bathroom, because that's where you're going to be doing your homework practice of your daily tasks. And so we can really put it into real life. So when, especially if they have any cognitive issues, maybe when they practice that with me, and that evening when they're by themselves, left to their own devices, they go into the bathroom or they go to the sink or whatever routine we've paired up their daily exercises with, and they can knock out their homework right then and there. So I think that there's a carryover aspect that's easier for people too.
Very nice. Very salient environment there. Thanks, Heather. And before we move on to Bernie, can you share why you enjoy implementing LSVT Loud in outpatient and telehealth?
Absolutely. It really is about reconnecting people, not just to successful communication, but seeing them reconnect to their world. So much of communication is about connection to family members, to community, to people on the phone, like grandkids or people that they feel like they've lost touch with. So seeing that connection coming back and seeing these faces that come alive, these smiles that start happening again, and the confidence that you see building within your patient over the 4 weeks. It really is those goosebump moments that I receive with LSVT Loud more than any other treatment. And it's so heartwarming. And to piggyback again and echo what Jenny said, it's fun. It's so much fun, not only for the patient, but as the clinician. If I'm having a low energy day, or I didn't sleep well, and I have a patient for LSVT, I come out of that session revved up and in a better mood. And I see the same thing happening to them, tenfold. So I think that fun component definitely echoes true here too.
Great. All right. Well, thanks, Heather. Thanks for those words of wisdom.
My pleasure.
All right. And then next up, we have Bernie, who's going to talk to us about LSVT Big and skilled nursing facilities and home health. So Bernie, if you don't mind taking a moment to introduce yourself to the group.
Absolutely. I am very happy to be here this afternoon to speak with you. I am an occupational therapist, have been an occupational therapist since 1984. I'm just thinking back on it. So we're almost there at another milestone. But in that time, I've done many different things, as a lot of you OT there have as well. And home health was where I landed for most of my career. And more specifically, more recently, I've been in clinical leadership. And currently, I am working for a company called Henry Ford Home Health. It's part of the Henry Ford Health System in the Detroit area. In my experiences in the past, I worked again in home health in different places and had the same kind of experiences as what Jenny was mentioning when it came to our Parkinson's patients. I would say it was probably those were the most challenging patients that I had in home health pre-LSVT big certification. And it was an opportunity to really effect a change with my patients. It truly did change the way I practiced. But it was one of those moments that came after my certification in 2008. After that, I was given an opportunity to join the clinical faculty of LSVT Global, and that was in 2011, along with everybody else who began for LSVT Big. So since that time, it's been a real opportunity to share the protocol and share these experiences. It's been up and down. For many of you who are on this call, maybe you're working in these settings. These are challenging times for those of us who are therapists working in home health in particular, and also in skilled nursing facilities, mostly insurance driven. And those are going to be some of the questions hopefully we'll have an opportunity to explore.
Yeah, great. Thanks, Bertie. Thanks for being here.
Yeah.
So to start, oftentimes patients that are in skilled nursing facilities or home health, they may be more advanced in their condition or have more cognitive challenges. So have you experienced some of those more challenging cases, and how have you still been able to help your patients make good progress?
Yes, it's true. These are more advanced patients. I was just reading an article recently about how 40% of people with Parkinson's, this was Medicare statistics, 40% do not even see neurologists. This was in 2019, 2020, much less movement disorder specialists, and how few of them even tap into therapy. So what often happens in the home health arena, and definitely in skilled nursing facilities, you kind of happen upon our patients who are more advanced in Parkinson's disease, and they really haven't had a lot of intervention, a lot of therapy for sure, and not the guidance of a neurologist or movement disorder specialist. So it's very challenging. There are also patients who are much more medically complex. You're often seeing a patient in home health, not because of Parkinson's disease, but because of something else. And in the skilled nursing facility as well. Often it's just as what Jenny had mentioned, we start seeing patients after a fall. It seems as though, there's some sort of a trigger that leads them into our system, and then we have an opportunity to help them. So I would say that, again, another big challenge that we hear about mostly from our LSVT certified clinicians is, but I can't always effect this protocol if the patient has cognitive issues. And so I want to be, absolutely recognize that these are patients that are challenging to work with as a clinician. They always are. But we have some unique opportunities, and LSVT Big is a wonderful protocol even to address their physical issues, as well as implement some of the caregiver training that's needed in order to provide some external cueing in those situations. And also, just to improve their quality of life and reduce the probability of moving from one level of care to another, to a more advanced level of care. So we have some real opportunities with our patients using LSVT Big. The best thing that I found about LSVT Big is its single focus. So our patients really blossom when you approach them with that single focus of Big, and you don't have to use a lot of words. And you have the opportunity to do the one-to-one treatment with your patients. These are all things that are unique to LSVT Big, I feel, and yet, they are extremely applicable to this population. So we have a really beautiful fit. And the teaching techniques, especially the modeling, are really beneficial for our patients, and we're able to, work with them in their home environment or in their home-like environment in a skilled nursing facility in order to really have some best practice carryover, working in context with your patients. You have some wonderful opportunities to actually effect some learning within that home environment. I just want to emphasize one more thing that's a real opportunity here in home health and even in skilled nursing facilities is that care partner focus. So we work a lot with care partners. That's a separate skill, isn't it? And it sometimes is a pathway in some of the home health pathways that I work with, you have caregiver competency that you're able to establish, and you're working with the caregiver in some opportunity for discharge planning, and also then for carryover into the community. So it's an opportunity that we have using LSVT Big to really address the complexities, the medical complexities, as well as the cognitive challenges.
Great, thanks, Bernie.
Mhm.
And then have you had any difficulty getting the intensive dosage scheduled in these settings?
So typically, no. In my past experience, no, because we've been able to flex the schedules, and we've been able to use the PT-OT partnerships. PT-OT partnerships are a wonderful innovation, best thing for the patient and best thing for your agency. If you're in home health, you have the opportunity to schedule and coordinate with another discipline, with your physical or occupational therapy partner, to provide everything that the patient needs based on the OASIS assessment and the clinical diagnosis information that's being sent in on this patient. And you have the opportunity to effect that plan of care with physical occupational therapists, PT assistants, and OT assistants as well. You have that flexibility just as you do in outpatient or other settings. I know that Michael's probably going to speak about this a little bit with the mobile therapy, but you can also play around with it a little bit. Sometimes patients need more physical therapy, sometimes more occupational therapy focus in their treatment approaches. The opportunities are just tremendous for that coordination of care. You're really able to meet those requirements. Agencies have a lot of requirements, home health agencies and skilled nursing facilities, regarding interdisciplinary communication. So you have a wonderful hook to hang this on, where you have the partners working on the LSVT Big protocol, but with different goals in mind. There is a wonderful overlap with the protocol, but again, different requirements or different goals are met, and the patient is the one who benefits the most. And there's a really good opportunity in home health right now, especially. I'll talk about the insurance in a few minutes. But you have the opportunity for subsequent 30-day billing periods where your patients who are more advanced in Parkinson's disease, what you find in home health, they really benefit from a maintenance approach. And you have that opportunity, and you have the scheduling flexibility. You can reduce the frequency if you want, and you can also speak with your managers and your agency leadership about the benefits to them of continuing to see the patient and reducing rehospitalization as well, which is another important thing for all of us in home health.
Yeah, great. Thanks, Bernie. And I think this would be a good segue into insurance. So have you had any difficulty with insurance reimbursement for treatment or follow-up sessions in these environments?
Well, so there have been a lot of changes in Medicare. PDGM, PDPM, I hate to speak in code and in acronyms, but these are plans that were implemented by Medicare in order to provide a little bit more of a managed care approach. So a patient is the payment for home health and skilled nursing is based on the patient characteristics. And that means that, you are perhaps limited in the number of visits that you have in home health, or the number of encounters that you may have in the skilled nursing facility. So there are things that you can do as a home health and a skilled nursing facility clinician to address this. Your patients are primary, your patients need the services, they need your skills, and the caregivers need that in order to take the patients home and be able to effect a good plan of care. So you have some opportunities to use your skill, especially in something like stimulability testing and a trial of LSVT Big. You have a wonderful opportunity to, assess and address, and perhaps then move the patient on into the next level of care, which could be an outpatient or a mobile practice as well. So it behooves all of us who are in these skilled settings, like skilled nursing facilities and home health, to have a little bit more of a continuum of care. Now, I work for Henry Ford Home Health, and they have a built-in continuum of care here. And we have lots of LSVT certified clinicians, both PT, OT, and speech pathologists. And they also have them trained in the outpatient setting. So there's a lot of movement back and forth. Perhaps your health system is like that, perhaps it's not. In other places, you may have to do something a little bit more grassroots, but it really makes sense for your patients to be able to offer them the opportunity to do a warm handoff to another setting, so that the plan of care so that the protocol can be completed LSVT big. So thinking about those continuums of care makes a whole lot of sense. Mm-hmm. So you have to think too, those of us who are in home health, we have the OASIS, that's the initial plan of care that's developed and sent into Medicare. And in the skilled nursing facilities, you have a plan of care that's developed that requires your input as well. We have an opportunity as therapists to really effect how much reimbursement your patients are going to get for both home health visits and skilled nursing facility length of stay based on our input. If we paint the picture of the patient's functional abilities, their acuity, their complexity, the opportunities for improvement, then you're really going to have a lot more of that reimbursement. So that's something that we emphasize here at Henry Ford also. A lot of, very ground level discussions with clinicians. Well, if you're thinking that this patient's going to improve, you have to show us where they are right now, and it has to be very realistic. So that means you have to see the patient promptly. You have to provide that collaboration of care with the nurse or whoever is the discipline that's doing the start of care. So you have that opportunity to really collaborate and provide what the patient needs. So you do have input, you do have control, you have more control than you think. I'm finding that more and more. So we have a couple opportunities to address that. And also, I touched on this previously, maintenance plans of care for our Parkinson's patients really make a whole lot of sense. I don't think they're used as much as they need to be. So you have some opportunities there to really advocate for your patients by requesting maintenance plans of care in order to keep them out of the hospital. I know your agency, I know your skilled nursing facility is on the hook for those type of quality markers. So you have some leverage there.
Great, thanks, Bernie. Some really nice guidance on those potential challenges.
Yeah.
And before we go on to Dr. Hyland, I'd love if you could share why you enjoy implementing LSVT big in home health or skilled nursing facility environments.
I feel like I already have, but I'll say it again. It truly changed my practice. I loved providing LSVT big to my patients in home health, and I also did it in outpatient. I also did it in a mobile practice as well. It's just the most satisfying thing to see people blossoming and the improvements that happen. I know we didn't talk a lot about the context questions that might come up, but when you're working in home health or when you're working in a home-like environment, you see so much. You have such an opportunity to make a change. And sometimes these are our patients, my patients were frequent flyers. So I would come back to see them again. And you had the opportunity not only for tune-ups, but to see how they were doing. So it was so satisfying and so rewarding to me as a therapist to see that and to hear the people that I managed even telling me the stories of how much better their patients were doing because of their skills and their touch.
Great. All right. Well, thanks for sharing that, Bernie. All right. And then last up, we have Dr. Hyland. So Dr. Hyland, if you can come on and go ahead and just tell us a little bit about yourself.
Thanks, Beth. As Beth said, my name is Michael Hyland. I am a doctor of physical therapy. I earned my degree from University of St. Augustine for Health Sciences back in 2012 on the East Coast of Florida. And I work in the Tulsa, Oklahoma Metro with my own practice, Hyland Physical Therapy and Wellness. I worked in a variety of settings. I've worked in acute care, outpatient, in the hospital setting, as well as home health. And then I started my own practice, which is mobile. that's about it about me, I guess. The spark that lit the fire of passion for treating Parkinson's patients was lit as a student in the classroom of my clinical neuroscience, one of my clinical neuroscience labs, where I learned about LSVT-BIG for the first time from one of our faculty who had just been recently certified. And it's just been a great journey from there.
Great. Well, thanks, Michael. We're happy to have you here. And can you start and tell us just a little bit about what the mobile practice model is? I don't think all therapists are familiar with this setup, so we'd love to just get a little input from you on how it's different maybe from outpatient and home health care.
Sure, that's a great place to start. Bernie kind of alluded to some of this in her presentation, and even to the point of saying that she had worked in a mobile practice where there was kind of some back and forth, or currently doing that. So essentially, think of mobile therapy as bringing the outpatient clinic to the patient. Because home health care, of course, is delivered in the home, but mobile is also delivered in the home. So the difference mainly is in, well, there's many differences in billing. That's the number one thing, is Medicare Part B is what is utilized for mobile practice as if it were an office visit in a physical practice or a physical clinic. There are many people that will, for various reasons, it could be PDGM requirements. Maybe they don't qualify due to their OASIS scores and or other functional scores for a longer stay in home health. Even if they do complete something like LSVT-BIG in the home under home health care with a home health agency, they may need a continuum of care into outpatient, and there are no restrictions as with Medicare Part A, which governs home health. There are requirements to be homebound to legally bill Medicare Part A for those services, but there are a lot of those people that don't necessarily fit homebound status that still have issues with going out of the home. They may still need caregiver assistance, and that is a burden on the care partner. There may be other physical issues. And so we don't have that restriction of homebound status since it's billed like an office visit. So we can deliver that care with that same level of insight into their home environment, their home life, and task saliency without the burden of the administrative burden of doing the Medicare Part A services.
Yeah, it's great. It's a really exciting model. So thanks for sharing about that. And oh, sorry, go ahead.
Just going to say, like I said on the slide, it's becoming more and more common as we progress into the future. I feel between self-pay services and home-based outpatient Part B Medicare services, it's really a growing field. So,
yeah, very neat. And have you had any difficulties getting the intensive dosage scheduled in that type of setting?
No, honestly, this hasn't been an issue whatsoever, because 9 times out of 10, if somebody is going to have an issue, those are not real statistics, but you know what I mean. Majority of the cases are going to be, as you cited earlier in the presentation, transportation barriers and things like that are going to keep people from coming into a clinic at some times. We bring the practice to them so they don't have to go anywhere. So that's a huge barrier eliminated there that would be a larger barrier to the dosing with LSVT-BIG or LOUD that we can eliminate. You can see that on this slide here, there are some folks that may not be able to tolerate, due to physiological reasons, may not be able to tolerate the 4 times per week when we very first see them. And if that's the case, then typically in our practice, what we will do is do 1 or 2 times, usually twice a week for up to 4 to 6 weeks, just to essentially get them up to speed physically so they can tolerate, they can increase their stamina and strength. When I've had students in my practice, which I have for a couple of years since the pandemic, actually, the way I like to explain it in an analogy is that with a house, you have to have a strong foundation to build upon. And if the foundation isn't strong, then the house is not going to stand up very well. So if you're starting with a patient that has a poor foundation, a lot of comorbidities, maybe a lot of physiological weakness and stamina issues for various reasons, then doing LSVT big at the full, 8 repetitions, 4 times a week for every exercise, they may not be able to tolerate that. So, and even their balance may not be to the point where even adapted exercises are a good idea at first. So I like to call it building the foundation, where we do that 4 to 6 weeks, doing it twice a week to kind of build that foundation up, setting them up for success when they can tolerate 4 times a week. And of course we can adjust repetitions as needed if they can only tolerate 4, and then we work up to the full 8. So there's various ways you can approach that.
Great. All right. Thanks for sharing that insight there. And then what benefits have you seen from being able to deliver LSVT big in their real world home environment?
Yeah, I think the best thing, absolutely the best thing, is it makes task saliency so much easier to determine. For example, if somebody's coming into a standalone practice, whether it's an outpatient clinic or outpatient hospital clinic or an outpatient orthopedic neuro clinic, you can really only imagine, unless they bring you literal pictures, you can only really imagine their home environment based on description. And for example, they might have an issue with coming from supine to sitting position on their bed, and they get up toward their left side. Well, you could replicate that somewhat with a bat table if you have a high-low table, something like that. But can you mimic the blankets or comforters that they use on their bed? Can you mimic the exact height of their bed? Because you haven't really measured it. So there's a lot of guesswork involved, whereas there is no guesswork when it comes to going into their home. And you could be having them do repeated sit to stand with the big method, the big reach, stand and reach. They may not, in some cases I've been into homes where some of their furniture is just not adequate to practice that. And sometimes it's actually hard to find good chairs to use for those kind of tasks because they either are too low or there are too few of them. So, or there's clutter in the environment. There's just a lot of variables that you can much more easily customize when you do see that in their home environment. Plus the fact that if a care partner is involved and can observe or assist with treatment, you're also eliminating the barrier of them coming to clinic to see and observe that. So those are some specific ways I would say that's a big benefit.
Mm-hmm. Yeah, definitely. It's a great salient setting there.
Or there's stairs, as another example. If they have a staircase, they need to go up and down. Their master might be on the 2nd floor and they're still using those stairs. Obviously, we want to keep them using those stairs as long as possible. What better way to do it than to have them walk up and down with big steps? It could even be the first step. Maybe their balance is poor. They don't have good railings. We might just practice, big toe taps or foot taps on top of the first step or something like that. You can build up to going up and down the full flight. But anyway, those are things you just can't necessarily imitate outside of the home.
Mm-hmm. Yeah, definitely. Well, and then have you had any difficulty with insurance reimbursement in your setting?
No, very limited. Very limited issues. Traditional Medicare obviously covers this if it's medically necessary. And with Parkinson's disease, the diagnosis itself isn't necessarily what gives you necessity. However, almost always there are impairments we can find that are either a safety risk or they've already had falls that we're trying to prevent and so forth. Typically, when we do a battery of tests with clients, 5 times sit to stand or 30-second chair stand, Berg balance scale, tug, all those tests that we put together, there's almost always something we can use that is within a fall risk category, almost always. So haven't had an issue covering this. And the only exception to that would be there are certain Medicare Advantage plans that could be problematic. We've got a local one that doesn't have out-of-network coverage, and they basically make it impossible to become part of their network. So you're kind of in a catch-22. And there are some exceptions outside of that with the larger companies that may be an issue, but it's very rarely an issue. And we've even had some clients, we've had one client this year self-pay for everything voluntarily because we couldn't bill their insurance. It was that local plan that I mentioned. And then in addition to that, with the Medicare, the soft threshold now, Jenny, I think it was Jenny that alluded to this, that soft threshold, as long as it's medically necessary, we can go over that threshold as long as we can justify it in our documentation. If we were to get audited, they would find that evidence there. But in order to improve that burden on the Medicare system, we, as Bernie mentioned, we can split PT and OT services to help split that cost up to Medicare so that we're not racking up basically their entire $2,100 for PT and speech combined, plus, but because OT has its own funding, so we can kind of split that up. And it also makes availability to the patient more in that sense. We can help more people at once when we split it up, whenever it's appropriate. And then I mentioned documentation already. And what I didn't mention here is that we will do maintenance therapy, as Bernie suggested. We do ours under Part B, of course. When I was with Encompass Home Health, we did our Parkinson's clients and some other people with dementia through maintenance as well. So it wasn't new to me to do that. It is a little bit of a gray area in terms of justification documentation for that, but it's 100% possible if you're careful about it. And for limited cases, we do maintenance for our clients, especially those that have some level of cognitive impairment who struggle with home exercise program compliance and or just doing it with proper good quality movement every time they do it, or safety issues with that. So what I said in this slide about supplementing with self-pay sessions, essentially in those cases, what we're talking about is when somebody is on a maintenance plan, let's say we can justify for a little while, once per week for a couple of months, maybe 2 to 3 months, they might volunteer to self-pay for a second session that week. So they're still getting twice a week in reality, even though Medicare is only having to pay for one session. And again, with maintenance, you're not going to be doing twice a week for the rest of the year. You're going to be trying to ideally taper that down. And that's what we try to do, is to kind of, as long as they're stable, we try to reduce those covered visits, just so that we're being ethical about it.
Yeah, thanks, Michael. And we just have one more question for Michael, and then we'll be able to wrap up. So if anyone in the audience does need to leave, I know we're at the top of the hour. Feel free to leave. You'll still get the credit for being on for the full hour, and we'll be able to send you a certificate. If you're interested in getting the certificate, you'll just need to email us. It's webinars@lsvtglobal.com. Let us know you watched the presentation, and then we can email you that certificate. For those that can stay on, we'd love to have you stay on for another 5 or 10 minutes to wrap up and answer any questions that come in through as well. So then, Michael, my last question for you was just if you have any other particular challenges that you've experienced with your LSVT big and mobile practice.
I would say the biggest issue we've had is, like it says here, to fit everyone in, because the demand is fairly high once people understand that it's available. And we are getting inquiries more often from areas outside of our normal coverage area. For example, this year we had a client in Wagoner, Oklahoma, which is about 45 to 50 minutes east of where I sit here, that was extremely interested in working with us. And we couldn't offer ultimately the full protocol for various reasons. Number one was he was still working and wasn't available 4 days a week, even though he's on Medicare, but he was still working. So we were able to do a hybrid approach of telehealth plus coming out to the home for the assessment visits, like evaluation, recertification, and so forth. And so it's just an example of somebody that we could have maybe done telehealth if they were available 4 days a week. But the drive time alone was enough to prevent us from really doing that in the home 4 days a week for sure. And also just because of time constraints, even locally, it's really difficult to do unless your hours are literally 7 to 7 and you're expecting your clinicians to work 12 hours a day, which isn't very conducive to a good lifestyle, in my opinion. But work-life balance is what I mean. But 5 to 6 sessions per day is about what we can top with driving time between sessions. Usually we're averaging 15 to 30 minutes max between patients. And so if you start at, let's say, 8:30 or 9 o'clock and you're trying to finish at 5, you really only have time for 5 or 6 people in that span, realistically, especially when you're doing LSVT big. And believe me, I've had days when I've done 5 or 6 people in a row doing the protocol, and it is exhausting. So, but we specialize in that, so I'm willing to do it, but it's a lot. So that's the biggest challenge, I would say, is just volume and trying to get it all done. And especially, there's not a lot of clinicians. We have a dearth of clinicians that are really interested in specializing in this niche. So trying to find someone else to do the work with us has been difficult to find locally.
Yeah. Well, thanks, Michael. Thanks for sharing that. Sounds like a thriving practice. So it's great to hear about that model. All right, so just in summary, what we've heard from the presenters here today is that efficacious dosage, so 4 times a week for 4 weeks, 1-hour sessions can be provided in multiple settings for both LSVT loud and LSVT big. They can also be delivered successfully to clients of various disease severity levels and cognitive abilities. And you've heard about how the exercises can be personalized and salient for clients in different environments as well. And we've heard a little bit about telehealth and how that delivery of both protocols can be beneficial to certain clients. And then I think we heard across the board about that importance of clear documentation and helping to show why your skill is required and why it's medically necessary. And then we've heard, which is great to hear from me, that reimbursement has been very successful again across the board with that clear documentation. I'd just like to make you aware of a webinar we have coming up in September. And so this is for both individuals with Parkinson's as well as, care partners or other allied health professionals. But it's going to be a webinar with a speech pathologist, a physical therapist, and exercise professional talking about the complementary relationship of rehab, therapy, and exercise. So we would love for you to join us or spread the word to clients, and you can register on our website here. You can see that email or the website address at the bottom. And then I've seen a couple questions come through. I think they may have been answered though. But let me just double check. If you do have a question, feel free to type it in the chat box. We can stay on, for 5 or so minutes and address those. If you need to go, you can also always email us. So it's info@lsvtglobal.com, and then we can direct that to the right panelist for you. And so let me just scroll up through the questions. So,
I'm sorry, I got cut off for a second.
Oh, that's okay. Okay, is there anything else that you wanted to wrap up with your mobile practice setting?
Not necessarily. I didn't know if there were any other questions pertinent to that I didn't see in the chat, but
let me see if there's
to
anything for mobile practice. All right, so Jenny or Heather, did you address the one about splitting the insurance with telehealth and mobile practice?
I think I saw that question, Beth. Was it asking about mobile practice or telehealth and home health?
So
Yeah,
I'll just go ahead. Oh, go ahead, Jenny.
I think Bernie did post a response to it.
Okay.
Bernie said that Medicare requires completion of skilled services with home health before payment for Part B outpatient. So unless you have anything else to add to that, Michael, he did put a response to that one.
Yeah, that was exactly what I was going to say. That question got my attention because I was like, yeah, you definitely can't do both. So,
Okay.
yeah,
All right. And then, so for those in the audience, if you open your chat, you'll also see the questions were posed to everyone. So you can see the question that was asked and then the responses from our panelists here. We'll see if there's any others that did not get addressed. Okay. So
I
here's
think
one that,
there was one, yeah, that just came in at the end there.
okay. So, Jenny, maybe if you want to take this one. So I'm getting the
Yeah.
impression that this treatment is more geared toward patients who are anticipated to recover and move on from some of their temporary intensity of need. Would this be similarly applicable to one with an ongoing brain injury, for instance?
Absolutely. So, with Parkinson's disease, we're not necessarily going to entirely fix things. We're not going to cure things. It's a progressive diagnosis where there will be ongoing changes and things to address. So it is kind of like living with a chronic condition, similarly to living with a brain injury or something like that. So I definitely, in our course and in our training of clinicians, we talk about how clinicians can use testing to determine if someone's responsive to this type of cueing and determine if they would be a good candidate for it. Personally, in my own clinical practice, I have applied this treatment to a lot of different diagnoses, and I would definitely consider someone with a brain injury as a potential good candidate with the right things that you're trying to address. We've done it with people like ambulatory spinal cord injury as well. We have done it with, and there's been research published on application to stroke. So there is a lot of different options of diagnoses that you could consider this treatment for. And we would use our clinical judgment and our skills from being certified in this treatment to determine if someone would be appropriate for LSVT big or LSVT loud treatment.
All right, great. Thanks, Jenny. I think that was a helpful response to that. I don't see any other, oh, go ahead, Michael.
just gonna say I would add to that by saying that, if it was only a matter of restoring, then we wouldn't even have a consideration for anything like maintenance therapy, because maintenance therapy is inherently recognizing that that person is not progressing further, and that they will need continued services to prevent regression. So, and we have clients with Parkinson's that have done LSVT big 2 or 3 times in the last 2 years that still fall. So you're not going to prevent everything from happening, but you might greatly reduce it. One of our clients that we're still working with, for example, literally was falling, and I don't necessarily mean smack your head on the ground falling, but going down on his knees or going down falling multiple times per day, 3 to 4 times per day. And his falls have been reduced to 1 to 4 times weekly after doing LSVT big. So on the surface, that sounds like he didn't get better, but compared to where he started, it's phenomenally better. So just have perspective there on the diagnosis. It does matter, but it doesn't really limit you from doing this just because somebody technically won't necessarily progress in every stage that they're in.
Yeah, great. I think that's helpful guidance as well there. And I think that was all the questions that I've seen come through. So I'll go ahead and just wrap up with the survey. So again, if you can take the survey, it helps us make the webinars the best we can make them. And so that will pop up on your screen once we exit the webinar. It will also be emailed to you in a follow-up email. And if you're watching on demand, you will have to take the survey to make sure that we know that you've viewed the webinar. So you can find that underneath the webinar description in the LSVT Global website or on the YouTube page. So thank you for taking that survey. We appreciate your time. And then just a big thank you to our panelists. So thank you, Jenny, Bernie, Heather, Michael. We really appreciate you sharing your time, expertise, wisdom, and guidance. So we really appreciate you being here today. And then thank you to the audience members for spending your time with us too. We're glad that you're here, and we hope to see you again on a future webinar.
Thank you.